Hello and welcome everyone. Today's journal review is on conservative oxygen therapy in mechanically ventilated critically ill adult patients. This is a study which was published nearly 6 months back in JAMA. This is called the UK-ROX RCT, and it was published in June. Now, why do you think oxygen therapy actually matters to us? Is it really that important that we will do such a big trial that it gets published in JAMA? It actually matters because it's very common. You will see patients coming in and you attach oxygen to every patient without even knowing the diagnosis. So it is actually one of the most common drugs that is being given in our ICUs, or for that matter in our hospital. Now, it is a double-edged sword. It's not that oxygen is life-saving and you can give endless oxygen and there will be no harm. No, there is a harm. Uh, just like it protects, that is, the low oxygen has its side effects and down points. The same is also there with hyperoxia. So excess oxygen is not without problems. So there is oxidative stress, there is organ injury, especially to the lungs and the brain, which must be kept in mind uh, regarding oxygen. Regarding the evidence gap, there is insufficient high quality evidence to tell us exactly what oxygen targets we should be using in our ICUs. There are in specific populations like myocardial infarction or in cerebral infarcts, but just into the ICU, there are very few trials which are there. If you look at the evidence landscape, previous RCTs, they've compared conservative versus liberal oxygen and showed no clear difference in terms of mortality. Some pediatric and subgroup data suggests possible benefit with lower targets also. So, finding remains quite inconsistent across the studies. So, this is the reason why they try to get this study done. Now, because oxygen is very common and even a small survival benefit could actually translate into a huge number of patients getting benefited, thus, they did a large pragmatic trial to answer this question whether less oxygen is actually better. So, what exact knowledge gap we have would further reducing the oxygen beyond the cautious levels that we consider, below which we don't go, will it alter the outcomes or even improve it? Does targeting lower saturation, that is 88 to 92, vis-a-vis usual therapy, reduces mortality in ventilated patients? Now, conservative oxygen therapy could reduce the 90-day all-cause mortality, was their hypothesis. So this was a superiority trial. So their hypothesis was to establish this superiority. The primary objective being to determine whether this superiority exists in terms of 90-day mortality. And in secondary outcomes, they're looking at the hospital stay, ICU stay, days alive, days free from organ support, compare mortality at multiple time points apart from the 60, 90 all cause mortality. They were looking at the hospital mortality, 60 days, 1 year, like that. And of course, they will also be looking for the safety outcomes and side effects. Now, what was the trial design? It was a multicentric, pragmatic RCT embedded in a routine practice across 97 adult ICUs in the England, Wales, and North Ireland. So the timeline was May 2021 to November 2024. The follow-up was done till 90 days endpoint and was tracked to 1 year. This was done by the National Registry. Research without prior consent used due to the emergency nature of this and frequent inability to obtain prospective consent. Who were included? They included adults, unplanned ICU admissions, receiving invasive mechanical ventilation or oxygen, and enrolled within 12 hours of eligibility. Exclusion being previously randomized in this trial, patient on ECMO, and clinical judged either strategy clearly indicated or contraindicated. Regarding the treatment groups, the conservative was to target a saturation of 90, that is 88 to 92, minimize the oxygen exposure, the lowest FiO2 to be used, lower alarm of 88 and upper alarm of 92. The upper alarm was disabled once the FiO2 reached 0.21. Usual oxygen therapy was clinician directed, no mandated minimum FiO2, no protocolized upper SpO2 limit, no upper alarm requirement. It was entirely the clinician's discretion. So randomization was 1:1 via the web or telephone system and permitted blocks stratified by ICU site and the diagnostic subgroup. Regarding the outcomes, as we have already discussed these in extensive details, the statistical power, it had 16,500 target sample size with an expected mortality of 37 and target reduction of 2.5. So from 37% mortality, they were expecting a mortality reduction to 34.5, which would give them a 90% statistical power with an alpha error of 0.05. The intention to treat with adjusted analysis included the site, the diagnostic subgroup, age, baseline oxygenation, the COVID-19 status considering the time, the calendar time of the year. Two interim analysis were done to look at the stopping boundaries. Regarding the population, nearly 50,000 patients ventilated in the ICU were screened. Out of this, they found 38,000 were eligible and they randomized them into 16,000 into two groups of 8,252 and 42 each. And the baseline characteristics were pretty good with median around 60 with IQR 48 to 71. Female were 38%. Oxygen matrix, the median saturation was 96 to 97. FiO2 was 0.45. PF ratio category was comparable across the group. The diagnostic subgroup distribution was similar between the two groups, especially in terms of the hypoxic encephalopathy, sepsis, brain injury. None were uh, abnormal. Regarding the oxygen exposure, there was a clear oxygen reduction in the conservative group with 30% lower supplemental oxygen exposure. There was a protocol violation in 42% of the conservative arm, and at least one non-adherence episode was noted. Regarding the deviation time, it was roughly up to 10% of the ICU time. Regarding the conservative group, the total oxygen exposure was 20.3 hours and median was 93 saturation with the PaO2 of 71. Total oxygen exposure was 28 hours with the usual care with median saturation of 95 and median PaO2 of 79. So time to in saturation in the target of which we had seen prior was 27.2%. The data from enhanced subset, that is time with saturation and less than 88% was slightly higher in the conservative group but low in the absolute terms. But the point that we need to note is that even though they were targeting 88 to 92, the median saturation was still higher. So it does, so there is a lot of protocol violation going on, and the time in that group was still acceptably different from the two. But then with such a small median saturation difference, we have to interpret the outcomes very carefully, especially 93.3 vis-a-vis 95.1. In terms of outcome, they saw no survival benefit, which was kind of expected if you look at the difference between the saturation, a 93 versus 95, not really much of a difference. It was a open label trial, so that could have affected this, as you can understand. So if you look at the mortality, 35.4 in conservative, 34.9 in the usual, with higher mortality in the conservative. So the risk difference was 0.7 and a p-value which was non-significant. And definitely in terms of our hypothesis, there was no reduction in mortality. Secondary outcome, there were no differences. Subgroup analysis, pre-specified subgroups examined the diagnostic subgroups, COVID, ethnicity, and they found no significant interactions. In terms of adverse events, serious adverse events were uncommon in both groups. Slightly more events reported numerically in the conservative group, but absolute numbers were low and not clearly linked to the strategy. No major safety signals as well. The clinical interpretation, according to the authors, is that they find a clear separation but no benefit. The context in healthcare system, usually the care avoids marked hypoxia, and 88 to 92 may offer little or no additional benefit. Caution is warranted and balanced approach is needed. We'll discuss in more details. First, let's see at the strengths of the trial. It was a very large trial, as you can see. 16,500 patients is a huge effort, and they have done a tremendous job in that aspect. It is definitely has got a real world significance. The study is very important, and it does give a lot of information to us. The design was pretty good. It was very large scale with low cost and pretty well done trial actually, and good enrollment also. Now, in relation to the prior evidence, where does it actually stand? The previous RCTs have and meta-analysis showed little to no benefit of these strategies. The UK-ROX adds to that and shows a little harm if we do it, and confirms that universal saturation target of 80 to 92 does not really improve the outcomes, but it doesn't do much harm also, nor it has any safety implications. Now, let's look at the mechanisms and future directions we are looking at. Regarding the neutral result, the harm from intermittent hypoxemia may offset the benefit from reduced hyperoxia. The baseline UK practice already is quite conservative. This is more important, I believe. As you can see, the saturation was very, very low in terms of the liberal group also, where the clinician were directing, it was 95. Most of the times in the ICU, you will see 99 to 100% saturation in most of the patients. In that kind of a scenario with 8,000 patients, to achieve a median of 95 shows that they are already conservative. And with that, they had a pretty large amount of time. The liberal group, they spent in the 88 to 92 branch as well. So it's not that they were not conservative, they were already quite conservative. And the optimal target for oxygenation could vary based on the study population. Here it was a very heterogeneous population. Now, what's next? Heterogeneity of treatment effect analysis using the UK-ROX data to the subgroup did not find any benefit or harm. So, results from this trial using liberal did not find much benefit. But we need to understand there are certain limitations of this trial. It was an open label trial. Mind you, everyone knows that there is a study going on in the hospital about oxygen conservation. So obviously every day when I'm in the trial, even though my patient is in the conservative group, I am still thinking about the oxygen. Mind you, if even if I'm not biased, I'm still thinking about the oxygen, which I may not be thinking probably if my patient was not in a trial. And the trial was not ongoing. So it does affect me as an individual, and it would have definitely affected the study participants. So open level is a major problem because they are aware, and it does influence their care, which is reflected also. They had a median of only 95. There could be a selection bias. It's very much possible, though it's not of much concern. Unlikely this could have been the reason. Limited exposure data. Detailed FiO2 and saturation data was collected only in 15% of the patients. We don't really know what happened in the other 85. So the whole cohort exposure was not really that well studied. The other limitation being, as you have already seen, there is a protocol adherence problem. The conservative group, they are not adhering to, and almost 10% of the time in the ICU, this is the time they have spent in the ICU. This is a huge thing. That is, if 10 hours the patient were in the ICU, 1 hour there is a violation. So this is a very long time of violation. Pre-randomized exposure was not standardized, so it could have had some, but very unlikely this has a major factor. And the comparative group, as we have discussed, is the main thing which has made the problem. The comparative was already very conservative. Economic analysis was not done. Unlikely that's much of an impact over here. Regarding the conservative study, the conclusion, among the mechanically ventilated patients, ICU patients requiring supplemental oxygen, it did not reduce. So we had similar outcomes in all the subgroups, and in the practice implications, it doesn't really change much. So, what are your bedside practice changes which you could be doing based on this? This study doesn't make much of a change in that, but one thing we should understand is treat oxygen as a drug. It is not just something which you attach, it has got a dose. Please see to it that you give it till it is required. That's the most important thing that we need to learn. Avoid the extremes. Hypoxia per se doesn't cause much of a problem, even if it is saturation is around 85 86, but then it can be tolerated, but the patient must be observed properly. Similar is a saturation more than 95. If you are seeing a saturation more than 95 in a patient always, then and if you're still giving that patient oxygen, then you must be a little wary about it. And obviously it has to be individualized, because various conditions will require a little higher oxygen, and in some conditions you can require a little low oxygen also. So don't push too low. There is no need to rush push it too low, but then you have to be worried if you are giving oxygen, my saturation is above 93 94. This is just a practical implication, not based on any particular study. Thank you for your time.